No, that's all good. I'll touch base as soon as I get the imaging from them.
Okay, everybody, thank you so much for joining us for another one of our specialist seminars. Today we have the very wonderful and lovely Dr. Evan Dryson, occupational physician. Dr. Dryson has worked with us at MAG for many, many years. We love having him in our rooms. His reports are excellent and he has a lovely manner with the claimants that he sees. His subject today is return to work after shoulder injuries, the effects of shoulder anatomy and degenerative change. May I ask that you all remain muted throughout the presentation so that noise from your home or workplace doesn't interrupt the quality of the recording. At the end of the session, there will be time to ask questions of Dr. Dryson, and hopefully we'll be able to finish up on time. You will be sent the recording within a day or so after the session. And of course, it's always going to be on our YouTube channel for you and your team to watch again and again. So, Dr. Dryson, we thank you very much for your time. Over to you.
Thank you very much, Michelle. So I think I need the next slide, please. So that's the title of my presentation today, Return to Work After Shoulder Injuries. And what I'm going to be particularly talking about is how the anatomy of the shoulder actually affects, firstly, the susceptibility to injury, but secondary, how it is treated and managed. So you'll all be aware that the shoulder joint is in fact a ball and socket joint, unlike say the knee, which is a hinge joint. So it's a very complicated joint in the shoulder. There is the ball on top of the humerus, the arm bone, and there is a socket on the scapula, which takes the ball. So it's important to remember that the shape of the head of the humerus is not in fact circular. It's not a globe. It is in fact oval, and this has important effects on what happens when you actually move your shoulder joint. So if we can go to the first picture there. Now that's just a diagram of the shoulder joint. I don't know whether people can see, but above the humerus is a small white area, just above that. Yes, right there. And that is called the acromion. The acromion is part of the scapula. So underneath the acromion is a space between that and the top of the humerus. So not unreasonably, it's called the subacromial space. And the subacromial space is, I would say, the hero of this discussion today. That's what we're going to be talking about. So through the subacromial space, there are various tendons, the rotator cuff tendons, which pass between the acromion and the top of the humerus in order to attach into the humerus and make the arm move. Now, what we've got here is what happens when you raise your arm sideways. Because the top of the humerus is not circular but oval, in fact, the subacromial space gets narrowed as you raise your arm, with the potential of pinching, squeezing, rubbing on the structures inside the subacromial space. If we could just go back a couple of slides. Yes, so I did a little bit of research for this presentation, and I found this interesting study that looked at a group of subjects, and they found that the subacromial space, that's the distance between the acromion and the humerus, is 7 millimeters in the average person when the arm is pretty much down by the side, so say 30 degrees of abduction. And look what happens when you raise your arm to 120 degrees, which is above shoulder height. The space, the subacromial space, goes all the way down to 3.9 millimeters. This is on average, of course, it varies from person to person. But you could say almost half the space has been diminished by just raising your arm sideways. Now, in normal health, that doesn't matter because there's plenty of room for the tendons of the rotator cuff. But say the tendons are a wee bit swollen anyway because of a bit of inflammation, or say the bursa is a wee bit swollen because of a bursitis, then that space gets narrowed even further and you get rubbing on the tendons every time you move the arm away from the body. And this is what's known as impingement syndrome. Okay, yes, let's go to the next slide. So, what is in the subacromial space? Well, there's a bursa. It's called the subacromial subdeltoid bursa. It protects the underlying tendons. It's like a balloon, a cushion, which is to make sure that the acromion is not rubbing on the tendons as you move your arm. There are 4 rotator cuff tendons, and each one of them has an effect on different movements of the arm. So, for example, the supraspinatus raises your arm sideways, the subscapularis raises your arm forwards, and the teres minor raises your arm backwards. Now, that's a wee bit simplistic because all of the muscles act together, and if they're not actually actively pulling on the arm, they're stabilizing the shoulder joint so that the other muscles and tendons can do their job. So it's a very complicated system of several muscles, several tendons running through this space, raising the arm in whichever way you want to raise it. There is also the long-headed biceps in the subacromial space, but we're not going to consider that much today. It flexes the elbow, but it doesn't particularly affect the shoulder movements. Now, it's not on the slide, but there is one further muscle, which is the deltoid muscle, which covers the whole of the shoulder, and it also has an effect on raising the arm sideways, forwards and backwards. So let's come back to anatomy. I told you about the acromion, which is sitting on the top of the subacromial space. And there are, in fact, different types of acromion in different people. So if it's got a flat undersurface, it's called type 1. If the undersurface is curved, that's concave, it's called type 2. And both of those don't have any effect on impingement of the underlying tendons because they're not poking down into the space. But look at type 3. It's what's called the hooked acromion, and in the anterior third, it bulges downwards like a hook, further narrowing the subacromial space. So if you're unlucky enough to have a type 3 acromion, something that you're born with, then you are more likely to develop shoulder impingement. And if you do, it's more likely to be worse. So next slide, please. So the rotator cuff tendons do age as people age. They become degenerative, they become frayed, they become worn, they get little tears in them. So this particular study, which I'm quoting here, by Leong et al., looked at the various risk factors for rotator cuff pathology. And if you are over 50 years of age, the risk of having rotator cuff pathology is 3.3 times greater than that of the normal population. If you have diabetes, the risk is 2.24 times above the normal population. And look at what happens when you work with your arm raised above 90 degrees. Even for people without rotator cuff pathology, the risk increases to 2.41 times the normal population. Now, I've also just added here that it's thought that psychological factors might have some sort of influence on impingement syndrome, presumably due to muscle tension, but things like high psychological demand in the job, low job control, that is, you can't stop and start as you wish, you can't change your position as you wish, job dissatisfaction, low support from fellow workers, have been shown to increase the risk of rotator cuff pathology. So let's look at the next slide. Thank you. Now, the acromion that we've talked about joins to the clavicle, and it's called the acromioclavicular joint. If you get arthritis in the acromioclavicular joint, the joint swells, and it too narrows the subacromial space because it bulges down into that space. So this is yet another risk factor for shoulder disease. So what are the causes of the osteoarthritis of the AC joint? Again, if you're over 50, you're more likely to have arthritis. Females are more likely to have arthritis of the AC joint. But secondary causes such as trauma, like an accident, a blow, falling on your shoulder, car accidents, things like that, can also damage the AC joint and start osteoarthritis in the joint. Heavy work, lifting, can also strain the joint and cause osteoarthritis of the joint. Now, I've just put here what you can do in the way of osteoarthrosis of the joint. It can be resected surgically, and what they do is cut off the outer end of the clavicle where it joins the acromion, so that the joint is effectively excised, it's taken away, and you have fusion between the acromion and the clavicle with good relief in pain, and also no longer bulging into the acromioclavicular space, subacromial space. So next one, please. This is another treatment that can be offered for rotator cuff and shoulder problems. You can replace the whole shoulder joint. And there are two operations that can be carried out. The first one is what's called anatomical, which means that the ball on the top of the humerus is replaced by an artificial one, and the socket on the scapula is replaced by an artificial one. So it mimics the normal anatomy of the shoulder, and it works fine. You have very good results as long as the rotator cuff tendons are still working properly. In other words, as long as they're not significantly damaged, torn, and so on. So what you can do if the rotator cuff tendons aren't working and you're getting a lot of pain from the joint, you can do a reverse shoulder joint replacement. Now that means that the ball, instead of being on the top of the humerus, is now on the scapula, and the socket is now on the end of the humerus. So it's reversed. Very good results in terms of pain relief and good results in terms of function. But remember that the rotator cuff tendons aren't working anymore. So it's only the deltoid muscle which is moving your shoulder, and you're not able to raise your arm much above 90 degrees. So even though it's a good result, good surgery, and gets good relief, you're not going to be able to return to activity involving the arm raised above the shoulder. So next one, please. So we're just going to look at overhead work, because everything that I've said so far has depended on the arm being able to be raised above shoulder height with good, healthy rotator cuff tendons. So overhead work, naturally enough, is defined as work with the hands above shoulder height. And it's likely, of course, to be manual work, So office workers, for example, generally don't do much in the way of overhead work. They might reach up to get a heavy file from a shelf, but most of the time their arms are by their side and they don't have any strain on the rotator cuff tendons. So next, please. So occupations in Australia and New Zealand have been classified by what's called the Australia and New Zealand Standard Classification of Occupations. And the most recent classification is 2022. And there are these various groups: managers, professionals, technicians and trades, community and personal service workers, clerical and administrative workers, sales workers, machine operators and drivers, and at the bottom of the list is the labourers. So if you think about it, managers are not generally going to be doing any overhead work. Professionals likewise are not likely to be doing any overhead work. Tradespeople are very likely to be doing overhead work, whether it's just stretching up and reaching, or whether it's work with holding tools above your head, or even lifting heavy items above your head. It's very likely to be seen in these particular occupations. Personal service workers, it is likely to involve overhead work if, for example, you're looking after aged care people, or you're doing other services for people. You may have to help them dress, you may have to help them shower. So the chances of raising your arms above your shoulders are probably reasonably high. Clerical and administrative workers, probably not much chance of overhead work. Sales workers, probably not much chance. Machine operators, yes, they are likely to be involving overhead work depending on where the controls are and what you have to do. Drivers, for example, often have to open and close the curtains on the trailers of their trucks. So to do that, you have to reach up above your shoulders to open and shut them. Labourers, very likely to involve overhead work. So let's look at the next slide. So what I did here was just to use the standard classification of occupations, and I just searched by overhead work, and this is the sort of list that came up from that search. Trades workers, we've already talked about. Cleaners, you can understand that cleaning high walls, cleaning windows is definitely going to involve stretching your arms up above your shoulders. Agricultural workers, you can imagine picking high fruit, vines, things like that. Even stacking pallets full of fruit may involve reaching above your shoulder height. Arboriculture workers, that's trees, very likely to involve overhead work. Crane, lift and hoist operators, operating controls, climbing ladders, getting up into a high ladder crane, you have to climb a ladder, so you're going to be raising your arms above your shoulder height. Telecommunications, you might be up a ladder working on a lamppost, fixing wires and so on, so you're going to be raising your arms above shoulder height. Structural steel construction workers, the same comments. So the next slide. So what we've been talking about here is what we're going to do with people who have damaged their rotator cuff tendons, who do have impingement syndrome, and who can't really do any work anymore that involves raising your arms above your shoulders. So if they are going to go back into their old job, what can you do? So there are mechanical answers like having extensions, added to your drill bits so that you can hold the drill down by your chest but still be drilling above your head. You can use mechanical lifts or hoists so that you can stand on them and be raised to the work where it's going to be done. You can use ladders. Clearly, if you're a tiler, for example, and you're tiling the upper part of a wall, the higher you are, the less you have to stretch and reach above your shoulder height. And then lastly, just for completeness, the psychological aspects. Improved job autonomy means that you don't have to keep on working. If you're getting problems, you can stop, take a break, go and do another job, which is not so arduous, and then come back to the problem area. Okay, I think that's the end. So I'm happy to take any questions from people. Michelle, I've lost your sound.
Silly me. Sorry about that. Thank you so much. That was very, very interesting indeed. I learned quite a lot myself. Before I ask others to unmute, I actually have two questions from people who were unable to attend. And the first one was one that actually I was going to ask after listening to you, and that is, why are females more likely to have shoulder rotator cuff problems?
I wish I could give you a good answer. I'm afraid I can't. I guess the reasonable answer is slightly different anatomy, but I can't give you chapter and verse.
Yeah, I mean, I wondered myself whether it's because traditionally women have less musculature to support the bony joint or something, but that was all I could think of.
Oh, that could well be right. It's a good answer.
The second question that I had was in relation to the the replacement ball and socket joint that you mentioned. Yes. And that was a question in terms of a person who plays a lot of sport. Would they have to engage in significant rehab or conversely a period of not using the joint before they could return to the sport?
You're not going to be able to return to the sport. So reverse shoulder joint replacement is really end of the line stuff. You know, it's what you can do to give people a little bit of improved quality of living, but it's no answer. It doesn't restore you to what you were before.
And are those surgeries long-term or are they short-term fix, as in, do they need to be revisited 10 to 15 years later?
Oh, no, they last very well. And as long as you are free of pain and you accept that you can't do the things that you used to do, then the quality of life is very good.
Lovely. Anyone else, if you would like to ask a question, please unmute yourself and pop in. If you don't know how to unmute yourself, it's the bottom left-hand side of your screen. Click on the icon that looks like a microphone. And we have no questions. Dr. Dryson, when that happens, it's because you already answered everything in your presentation. That was really excellent. And I found those diagrams very helpful as well. I'd like to thank all of you for joining us for our Meet the Specialist. And as I said, the recording will come out to you within about a day. And you can, of course, see this on our YouTube channel. Thank you so much, Amber. We're getting a few thank yous for the session, Dr. Dryson.
Oh, good.
Thank you so much. Very informative, says Farouz. So anyway, thank you, everybody. Have a great rest of the day, and we'll see you at the next one.
Okay, thank you.